and welcome to lecture 5 of the How to Prepare for Your On-Call Surgical Series webinar series. Today, back by popular demand, we've got Ben, who's one of the doctors that I've worked with in the past, and he did a previous lecture in this series. And today he's going to be talking to us about discharges and how to make the most of our MDT. So I think there's still some people joining, but I'll hand it over to you, Ben, and you can introduce yourself.
Sure. Hi. So hi everyone, like Jen said, my name's Ben, and I've done quite a few surgical jobs through my F1 and F2, and so I was really pleased to come help out in these lecture series on preparing for your surgical on-calls, because I know it's something that we're all probably quite nervous about before we start work. So this lecture is going to be on how to do a concise discharge summary. Though those are the jobs that I've been through, so I've done 8 months of T&O. And I'm on my general surgery block where I cover urology and orthopedics as well. Generally, as an F1, you tend to do more ward-based jobs, so this lecture's focused more on that. And then when you get to F2 level in surgery, you often get more involved in the clerking and the surgery side of things. So this lecture, we're going to go through discharge letters, and then the second section will go through how to make referrals, and the main people that you'll be making referrals to through your day-to-day job will be radiology. But then we'll also talk about generally how to do a specialty referral and come across like you know what you're talking about. And then we'll finish off briefly by just touching on some of the key members of the MDT that you work with in surgical jobs and how they tend to work. So we're going to start with a sort of a case again that we'll work through and sort of talk about discharge letters as we go. So if everyone gets their chat box open, we'll do some interactive slides as we go, just try and keep it interesting. So you're on a weekend on call as the F1 and it's 1 p.m. in the afternoon and you've been bleeped for about the 15th time today. So doctor, this patient needs an urgent discharge letter as transport's on the way. So they tell you down the phone, Mrs. X is an 80-year-old lady. She's 2 weeks after having a right hip done and she's going back to her care home. So if you just open the chat box, what's going through your head when you see, when you've got this situation in front of you? How are you going to, what questions do you need to ask to try and prioritize how urgent this job is? What do you think about the care home? What might you need to know? What about the transport? What about the patient? What would you want to ask the nurses about the letter? So just try and pop some things in the chat box as to what will be going through your head at the moment. And then we'll go through sort of what I'd approach this and the way that I'd do it and what thoughts I'd be having. So I've got my chat box open, so fire away any little thoughts. Yeah, brilliant. So Joe said any recent consultant review. So that's a really good point. So essentially who said she can go home? Is the care home set up? Yeah, brilliant. So do they know that they're accepting her back and what level of mobility are they accepting this patient back at? And is she medically fit? Brilliant. Thanks, Sarah. So moving on. This is how I try and approach this scenario. So the first 3 questions that you want to ask yourself is 1, can this patient actually go home? So that is going to be the yes or no of whether you actually need to do this job or whether you can save time. And if she can go home, who has said that? Has there been a recent ward round that's documented that she can go home if X, Y, and Z are met? Or is there a post-op note that gives clear instructions as to when this patient is able to leave the hospital? And then if someone hasn't said that they can go, are you comfortable making the decision as an F1 about whether this patient can be discharged? In most jobs, I would say probably not. You'd want to at least have your SHO or Reg either have seen the patient or be discussed with over the phone as to whether they can go home. But for some patients in orthopedics, it usually is down to the F1 to decide if it's at the weekend, if it's a young patient and it's clear from their post-op note that they can go home. If, for example, they're using their crutches okay, you know, a young 30-year-old who's broken their ankle, that would be fine. And then what do you need to ask to prioritize this task? So when's her transport coming? i.e. how much time do I have until I need this letter ready? And is there any way that we can delay this? Things that you can think of is whether the care home has a cutoff time. So sometimes care homes will accept patients up to about 6 p.m. So essentially, if you say you leave an hour for transport, you've got 4 hours to sort out this job. So if that was the case, it wouldn't be super urgent. And then how long is this letter going to take you? Has anyone started prepping the actual information? Has anyone started prepping the medicines that she's going to go home on? And the most important question, when is pharmacy open until? I.e., if this woman needs something important to go home with, like her VTE prophylaxis, are we going to be able to give it to her? And then just to note, like, this is something that you will get bugged about a lot in your working day. And it can feel like it's not a very important task because you'll be dealing with lots of other more clinically urgent situations. But for the nurses, they get a massive, massive amount of pressure from bed managers and site managers and the matrons to try and clear beds because patient flow is really important. But just always bear in mind, like, no matter how much pressure you get, you're the one that's making the decision where your time goes. So if you think that there's a job that's more urgent or a patient that needs your help before a discharge letter, patient safety is always more important. So there is no such thing as an urgent discharge letter in my mind. But just be clear to the nurses if you have got other things going on, what your ETA to the ward is going to be. So you check the notes and you see that the consultant for this, Mrs. X, has said she can go home tomorrow to her care home if she's been weaned off oxygen, and physiotherapists are happy for her and her mobilization. And she's to complete 7 days total antibiotics for a hospital-acquired pneumonia. So you check through with the nurses. She's been off oxygen for a whole day. The physio are happy in that she's not desaturating when she's moving. And the home has a 5 p.m. cutoff and no one has started the letter. So what's your ETA? These are your current jobs. So from all your bleeps before in the day, you've been on the ortho ward round, you've been on the urology ward round, whatever you've been doing, you've got 5 things to do. A 6-year-old who's got 15 minutes of 10 out of 10 central crushing chest pain. You've got some routine bloods that the phlebs have missed on their ward phleb round in the morning. For general surgery, you've got an urgent scan that needs requesting query perforation. You've got this letter, and most importantly, you've got your lunch. So A to E, have a think, what tasks might you do from each of these jobs first and what might you leave later on? And just pop in the chat what sort of order you're thinking. You don't necessarily have to order all of them if you don't want, maybe just which of the couple would you start with, which might you leave till later? And if you think you're putting anything that others might disagree with, why you'd do that. So first one in, we've got chest pain, urgent scan, the letter, lunch, and then the routine bloods, yeah. And then similarly, chest pain in the urgent scan first, and then a slightly different order. The letter's gone to the back for that one with your lunch later on. Yeah, the scan request first, the ECG. Bro, yeah, all good ideas. So, I mean, not that it's necessarily the only way to do it, but the way that I'd approach this on call would be to, I mean, you'd have received these bleeps already. So I'd hoped that for that chest pain patient, you'd already be asking the nurses to do an ECG. That's probably the most important thing because that's going to guide your management for that patient. Then requesting a CTPA should be fairly quick. So I'd probably do that quickly and then let the general surgical team know that you're busy with this lady with chest pain. Review the chest pain patient. And then this is where the sort of non-urgent TTO thing comes in. If you can find time to fit your lunch in on call, just always take your lunch because before you know, it'll be 4 o'clock and you just won't be working effectively. So take your lunch, do this letter, but sometimes if pharmacy's closing, you might want to send the medicines off before you have your lunch. And then think of those routine bloods that have been missed. Will they alter the management if they're missed today? Is there a blood test that needs to be done to decide if someone can come off antibiotics? If so, that probably needs to be done. But if someone's just put them out and you can't see why, and there's no clear indication, then I'd put them out for the day after. So you've done all your urgent tasks and you're on the way to go see Mrs. X and her TTO. So discharge letter or TTO to take away or to take out usually is electronic in most trusts, and it will be a sort of pre-made proforma that you just fill in. So there'll be different types. So usually it would be like an admitted patient proforma, and some specialties will have their own because they'll need different boxes to be filled in. And sometimes you can get away with doing a much shorter letter if someone's only come in for, say, a day case surgery. Within that letter, you'll usually have sections like their history of stay, so what's happened, what investigations and results have happened from their admission, what they've had done, what's been treated, what operations have they had, any medication changes that we've done to their meds on admission, what their VTE, like their prophylaxis plan is for blood clots, any follow-up plan, any actions that the GP needs to be aware of, any significant events that have happened and what their resus status is. And we'll go through those in a bit more detail later, but just to get an idea of what actually happens to a letter. So once you've done all your sections, and also at the moment, whether they've had COVID, whether they've had a negative COVID result, etc. And some care homes actually want another swab just before they're sent to check that they're negative. So once you've done your bits, it usually goes to the nurses and they'll fill in sections that might be relevant for care homes, such as their nutrition, their swallow, what their mobility is like from a nursing point of view, and any community nursing referrals that might be needed for ongoing dressings. It then goes to other members of the MDT, like the physios and the OTs. And then the most important people that it goes to from our end is the pharmacist. You'll often have completed a letter, 2 hours ago and think you're out of it and you've done the job. And then you'll get a bleep 2 hours later. Hello, did you write this lady's letter? And you're like, oh God, yes, what have I done wrong? But they're a really good safety net. They find things that you might not have thought of, or, incorrect doses if you've been prescribing in a hurry. They then dispense all those medicines and deliver them to the ward. And any controlled drugs, so that's any drugs that has to be signed for and signed out of a cupboard and out of a book. We need to be really careful when we're discharging patients with these medicines. And it's really important to check in your hospital what the protocol is for, say, discharging a trauma and orthopedic patient with oxycodone or morphine. Often there'll be a limit on the quantity that they can have, and there's often specific quantities for each drug that you can supply. So you'll need to know, often pharmacy will put a list up, how many mils the bottles are for morphine, because you need to know what to put on the letter. And then generally it's a paper copy that you have to sign your life away on with your name and the date, and the patient address normally has to be in view to make sure it's for the right patient. And then when all of that is done, they get discharged. So what's actually put on the letter? Essentially, the way that I think of it is, imagine that you're a GP and you're receiving this letter. What do you actually want to know? So you don't want loads of, massive detailed explanations of what's happened. You want their presented complaint and the date that they came into hospital, any past medical history, which is really useful for us as juniors looking back at previous letters to try and get an idea of what someone's past medical history is. The actual history of presented complaint, and then any inpatient issues. And I find it easiest just to list each of these issues, like issue 1, broken hip, the state of the issue. So whether it's ongoing, whether it's improved, what treatment it had, and whether there's anything else that the GP needs to do for that. Any investigations and results. So don't just copy in all the blood tests, only put in blood tests that are important for the GP to know, such as, they had an AKI, and their Usinese went off, and so you want the GP to repeat them. You'd want that listed in the investigation section. And any important scan results that led to them having, theatre or operations. And then anything outstanding, so that any blood tests that haven't come back yet, especially in district hospitals, some fancy blood tests, like fecal calprotectin and things like that, they might get sent off to another hospital, so they might not be back before the patient's discharged. And does any blood test or investigation need repeating? And if so, who's going to do that? When is it going to happen? Generally, if it's after 2 weeks, it's fine to ask the GP to do things. But if you're asking the GPs to do bloods within a week, it's not feasible. Sometimes the GPs won't see the letter for ages, so it's not very safe to leave that up to the GP. And then in the treatment section, clearly like what they had done, what date. And then the medication, which usually takes the longest, to be honest. Have a look at what they came in on. Have we stopped anything? Since they've come in, have we started anything new, or have we changed any doses of any of the medicines that they were on already? And if you have started any new indications, what have you started it for? That's really important, because otherwise the GPs just have no idea. And how long is it going to go on for? And don't forget any VTE after surgery. So just as an example, I won't read it all out because that would be really boring. But this is what Mrs. X's discharge letter would have looked like. So what she came in with, her background, her history of presented complaint, and then I've just split her issues into issue 1, issue 2. So it's really quick for the GP to read, right, she broke a hip, this happened, and this is what's going on from that. She can fully weight bear on it as she's able. She also had a chest infection because, she developed an oxygen requirement. She's off the oxygen now, it's resolving, and she's safe to go home. And then in the investigation section, what her chest x-ray showed, and the fact that in her medicines we've stopped one of her blood pressure tablets because she had a postural drop. Like, that's quite succinct and just shows the GP what's been going on. Next, the VTE plan. This is really important in surgery especially. So make sure you check the post-op note. That will often give you the instructions if you can actually read them. If someone's non-weight bearing, for example, after an orthopedic operation, commonly on ankles, then they'll need 6 weeks to go home with, or any major abdo-pelvis operations, any big resections for cancer, they'll often need 6 weeks as well. And just to think, when you're going through the medicines, if they came in on anticoagulation, when are we restarting that after the operation? Has the surgeon actually put in, restart on day 1 or 2 if dressing clear? Like, you need clear instructions as juniors to go off. And if it's not clear, that's something that you need to sort of raise on the ward round and make sure your seniors are aware that you're not sure what's happening. Warfarin clinic is different in every hospital. Some hospitals, they have warfarin pharmacists, and so your job is done for you. They literally arrange the blood test monitoring. If someone's discharged, they'll arrange getting them back into warfarin clinic for monitoring and adjusting the dose. And in some hospitals, it's up to you and the doctors. And you have to send off a formal report after their admission to the clinic to say what they've had done, what their INR was through their admission. So that's just something to bear in mind as well. Follow-up, this should be found either on the post-op note, or sometimes it will just be mentioned on a random ward round that the consultant is under. I'll follow up my clinic in 6 weeks after they're discharged. So sometimes it takes a bit of digging. And again, when you start at a new hospital or on a new ward, or even in a new specialty within that ward, how is it organized? Is there a clipboard that you need to put a sticker on? Is it an email to a clinic, or does the ward clerk pick it up from the letter and it's all sorted for you? And then just simple questions: who, when, and where is following up this patient, and is there any requirements? For example, a lot of the orthopedic follow-ups will have an x-ray when they arrive for their follow-up to check that the fracture is still stable, and whether the plaster or boot or something can come off. If they need any repeat bloods, I've been caught out with this before, sometimes they need a phlebotomy form to take back to the hospital, so don't forget that. And similarly for further imaging, how urgent is it needed, and is there any preparation needed for it? And then actions for the GP. So this will probably be mentioned as you go along, but there's usually a box on the TTO that just clearly says, what do you want this GP to do? And I usually say, could GP kindly, because at least makes it sound like you're trying to be nice. And things that the GPs are often asked to do is repeat bloods if there's been any AKI or severe kidney issues. If there's been any significant change to the patient's status, or they're now moving to a nursing home because they can't cope at home with their broken hip, please be aware this patient is now being cared for in a nursing home. And again, just outline clearly any medication changes. Also to note in this section, it's quite useful. You can ask the GP to clarify something. Say if you're unsure why someone's on a certain medication and the patient isn't sure as well. Some people come in on antiplatelets and none of us can work out why. So it's often useful just to pop in that section if you haven't been able to get through to the GP on the phone. Why? Please can you clarify the indication for X, Y, and Z? And then coming towards the end of the letter, any significant events that happened during admission. So this would be if their resuscitation status has changed. So if you've discussed that with them and they're now not for resus. If you have done that, who have you discussed it with from the family? Is the patient and the family aware? And is that to go until the end of life, or do you want the GP to review that at a certain time point? And then any other significant events like complaints or anything else that's happened in hospital, like an inpatient fall that's led to a fracture would be quite a significant event, and want to just make sure that was highlighted on the letter, and any investigations that had gone into place for that. So back to Mrs. X, that would be what her discharge letter would look like. Every trust will have their own protocol for VTE. So when you start surgical jobs, I'd recommend, just asking your seniors, do we have a protocol for VTE prophylaxis after operations? And just, make sure it's printed out somewhere in the doctor's office, because you will every single time you write a letter, you'll have to look it up until you know it by heart. And then her follow-up, so routine hip hemiarthroplasties don't get any follow-up at all. But because of her chest infection, she'd need a repeat chest X-ray in 6 weeks. And that's usually, orthopedics has shared care. So any elderly patients are usually cared for jointly by an orthopedic surgeon and an orthogeriatrician medical consultant. And it's usually the medical consultants that would follow up on any medical issues that have happened during admission. And then the actions for GP section and the significant events bit. So just a bit of a summary on the sort of discharge letters section. That's the first bit done. Is you can make your life and all your colleagues' life so much easier if you're ready and preempt all of these decisions on ward rounds. So if you're seeing a patient and one of their medicines has been withheld by the clerking doctor and it's day 5 of their admission and they've still not had any of their antihypertensives, are we restarting it, or do we want to stop it and let the GP try and restart it if they think it's appropriate? If they're on antibiotics, surgeons love prescribing antibiotics without any end date. So almost everyone that comes in through ED for general surgery just seems to end up on amoxicillin, metronidazole, and gentamicin like it's actual candy. And there will not be a duration on that. It would just be indefinite. So just make sure we're asking things like, can this go to oral? If they were discharged, how long would you want the course to be for? And if we've started any new medicines as an inpatient, do we want the GP to continue this? And do you want any follow-up? So just try and ask those on ward rounds and you'll make your life easier. If you have easy shifts, you'll often get suggested to prep the TTOs. If you do, make sure you say really clearly what date you've prepped it and the fact that it is prepped. We've had numerous cases on our orthopedics ward where we'd prepped TTOs for patients who weren't ready to go home, but we were just getting ahead of the game to prep. And some of the nurses actually took it upon themselves to decide that because the TTO had been prepped, we'd decided that the patient could be discharged. And the consultant came in the next morning and just found that 2 of the patients had left the hospital and been discharged to a nursing bed in like a rehab hospital. And they were mad because this patient obviously was not meant to leave the hospital. So if you are prepping, just be really clear. And always keep in mind that, the nurses will be hounding you for these letters, but at the end of the day, patient safety is much more important. So before we move on to the rest of the talk, does anyone have any questions about the very exciting world of discharge letters? I know my last talk on abdo pain and vomiting was a bit more exciting, but you will actually spend most of your life doing secretarial jobs like this instead. Right, so I don't see any questions at the moment, but fire away later and we can always do questions at the end if anyone does have anything to ask. So next we'll go into radiology, referrals, and the members of the MDT. So radiology, I just sort of wanted to go through simply, what actually happens when you put a radiology request in and what you need to do. So some words that will be flown around and you won't really understand what's happening. Well, at least I didn't, because I wasn't a particularly active med student at partaking in everything. Requesting means that you put a request in for a scan. Vetting means that you've put a request in, but you need to get a radiologist, so one of the doctors, to actually look at your request and say, yeah, you can have that scan, or no, I don't think that's appropriate. Accepted means they have accepted your request and they said they'll do the scan, but they haven't said when, and they haven't said, how urgently they're going to arrange that. Rejected means that someone has looked at that request and thought that's not appropriate. Sometimes they'll reject it with a message like, not appropriate, please consider this, or sometimes they will just reject it outright. Often this is things like, say in general surgery, if a patient has had an MRCP, to assess for gallstones and whether they're going to try and do any intervention. And a consultant will sometimes request an ultrasound after this, which is a bit of a rogue move because that's really not going to add much. That will often get rejected without an explanation. So if it does, just phone up and ask why, and just say that your consultant's asked for it. And then once you've got an appointment, that's when it's been booked in. So to go into a request is almost like a mini SBAR. So, what the patient's age is and what they came in with and what they're currently complaining of, if they're different things. Any recent operations or treatments, and then how the patient is at that moment, what are your examination findings? Are they really unstable? Do you need a portable x-ray because they're on 15 litres non-rebreathe and they're really struggling? You wouldn't want to send them down to the department. And then the most important thing to put in is why this scan. So why is this scan going to tell you the answer? And if so, what do you want it to tell you? So what are your differentials? And is it urgent? Have you discussed it with one of your seniors? That's a common question as well. If they see a request from F1s just flying in for CT abdo-pelvises or CT hips to assess a fall on the ward, they'll want to know whether your regs know about it. And then there'll be sections for your name, grade, and bleep number. And then just a note for radiographers, they organise the scans and perform the scans. So if there's any scan that you need out of hours, such as a chest X-ray, that's a simple scan, so you don't need it vetting, but you need to chase it up, then it would be the radiographer that you would bleep or contact to try and arrange out of hours or urgent scans. And they're useful to go to if you want to chase appointments for scans, or if you've booked an outpatient XYZ, have they got the request? Do you need to do anything else? And a few things that will catch you out when you start. If people are going for any scans with contrast, the radiographers and radiologists like a pink cannula in the ACF for the contrast to go through. And that's because they need the contrast to go in relatively quickly in one bolus into a large vein in order to get the correct imaging and series for like CTs or MRIs. If someone's U's and E's are particularly bad, or they've got an AKI, they've got a CKD, different trusts will have cutoff levels for creatinine or EGFR as to when they'll let the request go through without a discussion. And say once the creatinine is 150, you'd need to discuss that with the radiologist, because you're really risking worsening of their kidney function. And is the scan actually going to give you enough benefit to do that risk? And that won't be your decision. That would be between the consultant and the radiologist. Often if they're borderline, the radiologist will advise doing a sort of IV bolus, pre and post contrast. So 500 ml bag before and after if their heart's okay. Brilliant. So we'll have a practice. This is one of the cases that I used in my last teaching session on abdo pain. So I'll leave the information up. If you were here a couple of weeks ago, you might recognize this history. If not, that's all the information. So you're on call and you've reviewed this 59-year-old man who's presenting with worsening abdo pain over the last 4 hours, and he's 5 days after a big operation for cancer. You've started initial management. You've let your reg know, who's agreed that you think either this could be an anastomotic leak or a perforation. He's busy in theatre, but he wants you to order an urgent CT abdo-pelvis. So you can either just write it down on a piece of paper, or type it down on your phone, or just think through in your head what you'd write. Or if you want to share with others what you think you'd put, write it in the chat box. I'll just give you all about a minute and a half or so just to have a look through that information. Try and draw out what you think is the most important parts to put in, and pop it in the chat box. And I'm going to have a sip of juice. Obviously, it'd be easier when you're doing it on a system, because there'll be usually set boxes to fill in. So have a think what you'd put in the main information box. Are there any investigations that they'd want to know about? And do you need to phone anyone to discuss the request? Stefan, I hope that's an introduction to your request. As it is at the moment, that might get rejected. And you might have an angry radiologist on the phone. Okay. Right, if no one wants to share, although I probably haven't given you enough time. Here we go. Joe Bradley. Thanks, Joe. phone the on-call radiologist. Yeah, you want an urgent CT for a 59-year-old male who's post-op hemicolectomy, a differential diagnosis for leak or perforation, his creatinine, and that you've discussed with the reg. That's really good. So that's all the main things that you need to put in the request. I mean, I didn't do this in a rush, so I've got a few more words in mind, but you've got all the salient points, Joe. So this would be a request for a 59-year-old who came in. He's presenting with worsening severe abdo pain and he's 5 days after an operation. It's really important to let them know that he's septic, so his observations are really unstable, and you're worried about peritonitic abdomen. You've discussed it with your reg, who's advised you to do a CTPA to rule out a leak or perforation. And then you want to kind of persuade them that as long as he is, that he is stable enough to come down to CT to have this scan done. So you could say something like he's received a fluid bolus, and if his BP was a bit better, you'd want to put that in to show that he probably is stable enough to go down. Because you're giving IV contrast, it will flag and ask for a creatinine and the date that this was, and different trusts will have cutoffs as to when that creatinine needs to be. Your name, your grade, and your bleep number. Make sure you call the radiologist to get it vetted, and then check if they'd like you to contact the CT department to talk to the radiographers and CT scanners to make a case for getting this done urgently. And then most importantly, let the nurses know what the plan is, because they'll be the ones organising the transfer. So that's a bit about radiology. We'll do questions for radiology, referrals and MDT right at the end. So specialty referrals, again, they'll take up a lot of your time on call and on the day-to-day ward job, and it will be different in every single trust that you go to. And when you start a new job, you'll go back to basics. So find out how it's done and how it's done for different situations. So often there's electronic systems for some trusts, and it's just a template form that you'll send off. Some trusts have paper referral forms for non-urgent referrals. Some will have emails instead. Some will have phones, bleeps, go through switchboard for urgent or non-urgent things. So just find out how it works in your trust. But generally, in any referral, you want to think who, what, when, where, why, and how. So who are you referring to? Do you want the SHO to make a referral to surgery? Do you want the reg to come and help you with a catheter that you can't do from urology? Do you need the consultant microbiologist because it's out of hours and they're the only person that's working? Or can you refer to a nurse specialist or liaison mental health? Like, which specialty do you want? And then within who can refer. So sometimes out of hours in some trusts, as an F1, you won't be allowed to phone the microbiology consultant on call. And they'll say that it has to be a registrar, which is ridiculous because your reg will know less than you about the patient because you're the one that will have been seeing them. And then just be really clear about what you want. Do you want advice? Do you want them to take over care? Do you want them to arrange follow-up? How urgently do you want it? Where do you want it, as an inpatient or an outpatient? Why are you referring? Again, one of the most important things. And if you're not sure, ask your senior. And if they can't tell you, maybe think, do we actually need to be referring this patient? And then just, simple things like, how do you know when it's been received? Is it something, for example, in my trust for endoscopy, we do it on pink cards that get sent there and they get lost all the time. So we tend to phone the day after and just check that the pink card's been received and whether they've got a date for the endoscopy. And if you're doing telephone referrals, those are obviously all really important things to think about, but usually the best way to present your information would be in an SBAR format. So situation, background, your assessment and your recommendation, what you want from them. And try and get them hooked early on. If you're referring if you're referring that chest pain lady to cardiology, you wouldn't start with, this lady came in 2 weeks ago and broke her hip. She's had an operation and then she got a chest infection. They've already lost interest. So you want to start with like, I've got an 89-year-old lady with a past medical history of hypertension who's presenting with 10 out of 10 central crushing chest pain. Like they're like, okay, cool. I need to pay attention now. So just make sure you give them like the most important information for their specialty first to try and get them interested in what you're referring. So just bits about the MDT next. So obviously in a lot of surgical jobs, the physios and OTs are like absolutely crucial in both recovering from operations and discharge planning and patient flow. So the physios will, make sure they're comparing patients' current mobility status after operations to what their baseline was. whether it's safe for where we're planning to discharge them to. If it's not, do we need to give them extra care at home, or do they need to go somewhere else, such as an interim, rehab facility, or do they need to go to a care home for full cares? And generally, in most hospitals, they'll have a way of grading mobility. So it's usually independent, stick +1, +2, and then Zimmer +1, +2, wheelchair or bedbound. In orthopedics jobs, the most conversation that you'll have with physios will be what the patient's weight bearing status is. This should be on the post-op note. If it's not, make sure you ask on ward rounds. Just preempt it, because you will get asked by the physios and they will be annoyed because they cannot do their job until they know whether a patient is toe touch weight bearing. So they can use their leg just tapping their toes down to balance, but they can't put weight through it, or whether their weight bear is tolerated, so they can put weight through their leg, but only as pain allows while the fracture's healing, or if they're fully weight bearing, so they can just wander around. If it's not documented, and you're really busy and a physio asks you, you can apologize and just say, it's not been documented anywhere, but could you please phone the consultant because I'm busy? Like they're well able to phone consultants. And then occupational therapists obviously work in conjunction with them as to any adaptations or equipment for the home, whether it will delay discharge and can they wait somewhere else. And they'll do things like, kitchen assessment and things like that. The surgical nurses and other people on the ward are really, really helpful, especially when you first start a new job, because they're so much more experienced than we are. So they're helpful for all things going in and out of a patient. So dressings, drips, drains, what is draining, where from, how much is normal, what color is normal, catheters, and any lines that are in, is it PIC, is it a central line, is it a PIC line, but is it only for TPN? So even I had a lady today who I got asked to cannulate, and I turn up to cannulate her and she's got a PIC line in. So I was like, why are we cannulating this lady? But it turns out they were saving both of those lumens, even though it was dual lumen, purely for TPN, and peripheral cannula for antibiotics. And they'd only use it as a last resort. So she needs to cannula access as well. And then other people that can be really helpful on the wards, it's the ward clerks are really useful. In some hospitals, they will literally just read your letter and arrange all the follow-up for you. If you're having any computer problems, if you're having problems chasing scans, they'll often know the shortcuts to get through to, their pal Jenny in the scanning department, who they've known each other for 30 years. So Jenny can get that scan for you. And if you're, clerking who patients come in under which consultant, under which specialty, where the rotas are, like they're just brilliant. And then equally as helpful, if you can find someone to do it, would be healthcare assistants or nursing staff for things like bloods, cannulas, or ECGs. But that's only if you can find someone that will do that for you. Often they claim that they've not had the training. And then honestly, the godsend for your life will be the phlebotomists. A good phlebotomist can save you hours of your day. Most hospitals will have a phlebotomy ward round once or twice a day, so in the morning and the afternoon. They're usually requested the day before and printed off into a folder or clipboard to tell the phlebotomist, who needs bloods and what they need, so they know what bottles to get. And one thing to mention, I've had friends on surgical jobs before that have the culture of that hospital will be every single patient gets a blood test every day on a surgical job, which is just ridiculous, because that cannot be needed. Those blood tests aren't going to alter management every single day. So if you are on ward rounds, I know it can be quite scary to sort of stand up to a senior or question a management plan, but just have in the back of your mind, will it alter management? And can you ask, they've had a blood test today, could we maybe check their CRP in 2 days' time instead? They don't like needles or something. And any unsuccessful bloods from the phlebotomist will come to you. But how do you know? Sometimes they just leave it on the back, on the side, and you will honestly find that you try to chase these blood tests at 2 or 3 o'clock in the afternoon, and you find out that there are 5 blood tests to do. And sometimes they're all urgent. So you end up doing a last minute phlebotomy round and everyone just has to grab a blood and go. And it can be really frustrating, but they do work really hard, and they often have really strict rules as to where they can take blood from. So for example, if someone's got fluids running in both ACFs and they're not trained to take from the hand, they won't be able to take those blood tests. So that's phlebotomy, and they tend to be in hours. Then clinical support workers tend to be quite highly trained at lots of other skills as well, such as cannulas and ECGs. They're often on a bleep out of hours for surgical jobs, and the nurses will go to them first for blood tests that they know need doing, such as a gentamicin level or a cannula that's failed. So often out of hours, you tend to just get the the cannulas that they can't manage. And then don't forget, if you're unsure what blood bottle to do for a random cancer marker that your consultant's asked for on a ward rounds, just phone clinical sciences and ask them what they want. And if any tests aren't back or you're not sure whether they've been received in the lab, they're often really good people to go to. And then this will catch everyone out, but group and saves are so time consuming, but obviously for a really important reason, in that you don't want the wrong person to get the wrong blood. So for most trusts, they have to be handwritten straight onto the bottle with no stickers or bits of paper, no spelling mistakes. They have absolutely no leeway. They will not let you go down and change your writing on the bottle. If they've never had a blood transfusion before, they'll need a first sample taken by one bleeder and a second sample taken by someone different. So you can't just put both out for the phlebotomy team. One of the doctors will have to do it. Samples tend to stay relevant for 7 days, and after that they'll expire. So if someone does need a blood test, don't just prescribe it unless you're sure that they've got a recent group and save. Just phone blood bank and ask, do we need any more? Because sometimes if they've had 3 units of blood from their most recent group and save, because that can introduce new antibodies from donors, they'll want a repeat sample, even though there's been one within 7 days. So it will catch you out at one point, but just try and phone blood bank early on if you've got any doubt. Microbiology, again, really, really useful, very helpful when there's quite a complex, microbiology situation going on. So if someone's had lots of previous cultures sent, or, you're treating intra-abdominal sepsis, but they've also got a chest infection or, a mouth infection or something, and the guidelines aren't clear, they're really useful to go through. They tend to be, in most trusts, through a switchboard or helpline. And it's in hours, there'll be registrars and consultants, and then out of hours, there's usually a reduced staff. Microbiologists are known for sometimes being a bit sort of hard at juniors down the phone. So just try and make your case for phoning as informative as possible. So make sure before you phone, you've kind of got in your head an SPAR ready. You've got the notes out. You've got any relevant investigations up on the computer so that you're ready to have a detailed chat with them about the patient. Both trusts that I've worked in, so I've worked in Leeds last year and Harrogate this year, use Microguide, which is a really good app. And it takes you through each body system, or it takes you through different sepsis guidelines and tells you which antibiotics to do. It has the oral swaps. It's really, really good. And if it's not clear where the infection has come from, just make sure you've sent off the relevant things before, because Micro will ask you to do it. So blood cultures, urine cultures, you've swabbed any wounds or anything that has pus coming out of it. You've done a chest x-ray, and then later down the line, they may advise you for, searching for more weird and wonderful things like endocarditis or meningitis and things like that. Another group of people who are very lovely, usually the cancer service team. They often comprise of specialist cancer nurses that are usually available for bleep or telephone advice. Often they know the patients from the community, so they'll be the lung cancer specialist nurses who will have been looking after patients for a number of months or years, and they tend to know the patients well before they even come into hospital. And depending on the trust and everything, they'll come around and do ward rounds and reviews to stay in touch with the plan. Similar with the oncology and hematology, you will get some weird and wonderful full blood counts back in your day, and the hematology consultants will just know what to do and you won't, so phone them. And then often for new cancers, there's usually just a referral form for an MDT. So where you think if there's a primary cancer that's come, you just refer that to that specialty. So you found a lung nodule on a CT, abdo, pelvis, thorax, and they've just found it in the lung, refer to the lung MDT. If it's unclear where the primary is, so you're not sure where this cancer's come from, or it's in two places at once and it's the first time anyone's found it, you'll often refer to the cancer of unknown primary, or the CUP team. And then obviously when patients come to being discharged, the cancer services are brilliant at following up the patients and making sure they've got, clinic slots or a telephone appointment done. And palliative care, one thing I want to just sort of drive home with this is that they're not only there for patients that you've deemed to be at the end of their life. Obviously that's what they are brilliant at managing. They come at it from all angles. They're really good at providing advice for symptom and, comfort control. And often when you start, it can be quite scary to be looking at the amount of morphine that someone's been prescribed, and if you get asked to, if you're in a trust that has paper drug charts, rewrite the drug chart. And I sent someone home today and had to do a community palliative care referral drug chart, and it had 150 milligrams of morphine in the driver just for a day. And you read it and you think, oh, surely they mean 15, or that can't be right. But they do work with really big doses, so they're really useful to get advice from early on. And often they'll come around and do ward rounds, either with the nurses or joint with the consultants, to check that everything's been managed well by the home team, and if the family's got any issues. They're also really good at sort of chatting with the families and the patients as to where they'd prefer to die. So if that is in hospital because they feel more comfortable there, have we thought of everything that we can to keep them dignified and comfortable? Have we got them a side room? Have we stopped doing routine things like blood pressures, sats, heart rate? That's not going to really change anything that we do. We change that to comfort observations. So instead of going and doing all that obs, we ask, are you in pain? Are you thirsty? Do you want any mouth care with the swabs and things like that? And then obviously the anticipatory medicines, which just treat each of the different symptoms, like morphine for pain, midazolam for agitation. Usually trusts, if you're lucky enough to have an electronic medication system, will just have a protocol that you tick, and it has all of the relevant medicines on it for the specific kidney function. So that's really useful to look out for. And if it is home, are they having community palliative care follow-up there? Do they need any nurses to go in? Like the TTO I did today, do they need some anticipatory medicines prescribed, or syringe driver prescribing? And if it's hospice, they're really good at organising how to get in there. And last but not least, don't forget the family, especially at the moment. I mean, visiting's getting a bit better in our trust, but I know some hospitals are still being quite strict with visiting hours. It's been so difficult for them to, just picture how their family member is doing without seeing them. And that's made conversations over the phone about patients that are dying, or difficult medical decisions that have been made. It's been really difficult for families to accept that, because the last time they saw their mum, she was out at Tesco doing her food shop, whereas at the moment she's unresponsive GCS4, and I'm trying to tell them that we're withdrawing we're withdrawing antibiotics, and we think that she's approaching the end of her life. So that's been quite difficult. In terms of family updates, generally, they'll just phone the ward and the nurses will give them an update. And if nothing's changed and it's just sort of ongoing day-to-day care, the things that families want to know about most is, are they eating? Are they drinking? Are they sleeping? Have they got any pain? And we won't particularly sometimes know that if we've not done the ward round that day for that patient. So the nurse is a much better place to give those sort of updates. But if anything has changed significantly in their plan, or how they're doing, like their state, if they're becoming unstable or deteriorating, or they have a significant event that the family need to know about, such as a fall, or worse, or a death, that should probably come from a doctor rather than the nurses. Through your F1, you will get, I think before I started F1, I thought, oh, I won't possibly need to be having, DNAR discussions with families or telling them bad news or new diagnoses. But I think especially as you become more confident through the year, you just learn so quickly, and you will be in situations where you're breaking really quite bad news to families, or explaining new diagnoses. But always have in the back of your mind, especially explaining scan results with new lesions, and everyone's question will be, well, is this cancer? If you don't think you can answer the questions, or that you don't have enough knowledge to answer the questions, just make sure you relay that to your registrar and just let them know that you're not comfortable doing it. But yeah, don't forget the family. So a bit of a summary just for the last bit of the lecture. If you're asked to refer to someone, make sure you know why so you can do the request, otherwise you'll look like an idiot later on. For radiology, just think, do you need to vet the scan and keep an eye about whether it's been accepted. In some smaller trusts, it's sometimes honestly easier. Trying to phone a radiologist can be like trying to find a needle in a haystack. Just go to the department and try and hunt them down. With the phlebotomy ward rounds, just be organised. You'll save so much time if you look through your list in the evening and think, who needs bloods tomorrow? You know, is anyone's hemoglobin dropping? Has anyone got low potassium and they're on replacement? You know, if anyone's on gentamicin, they should have Usinese every day. So just try and think through who might need blood tests and save yourself some time. And then try and hook people with your SBAR early on, and be ready for questions. And one thing that you will find, especially when you start, and perhaps less confident, is that you will get some very, angry, dickheads on the phone just giving you grief for trying to refer a patient. But try not to take it personally. Like, no one should go to work and get like screamed at, but just be calm and confident. You know, you've either been asked to refer this patient to them by your senior, even if you don't think it's right, you've been asked to. My consultant has asked and thinks that this is a valid referral, or you're referring that because you believe it's in their best interests. Just try and bring it back to the patient. And it's quite hard for someone to stay angry at you if you just bring it back to, well, I can understand why you're frustrated, but, at the end of the day, this lady needs her CT because, it's the safest thing for her. And yeah, the MDT is one of the best things about working in hospital. Like, it's so sociable. You get to meet so many people, and yeah, they're just amazing. So use them well and your job will be fun. So we'll take any questions from any part of the lecture. And that's the feedback link for this lecture, which is the QR code. So I'll just open the chat box, and I think Jen will probably help me if there's been any on the Q&A section as well, and we'll just go through bits and bobs.
Fantastic, Ben. Thank you again for such a useful lecture. I don't think I ever had any teaching about discharge letters before I started work. So it's just so useful, and it makes up such a massive proportion of your time. So feedback, guys, while we're doing Q&A, if you could just do the QR code. It's so useful for the whole of the webinar series, and also for Ben, who's fantastic. And we can also kind of cater these webinars for things that you might find really useful in the future. So that would be grand. So there's a couple of questions in the Q&A that Ben can answer or we can discuss together. The first one was, if there are bloods that need to be chased within 2 weeks of discharge, who should follow them up if not the GP?
So if you are sending bloods off within 2 weeks, you need to just check most bloods that will be requested under a consultant's name, so who they've been admitted under. And it's usually the consultant's job. They're not just on the wards, they have office time, and they should get any blood tests that are coming back through. So it's normally the consultant, but just check. Some departments work by having a, so for example, in pediatrics, at the bottom of our Word handover sheet that we had to type every day, bane of my life, you would put any patients that were discharged with anything outstanding at the bottom, and it would be the juniors in the next couple of shifts duty to check that job and write the date that they'd checked it, so we just stay on top of who's looking at it. So it'll be different in every job, but usually the consultant.
Fantastic, thank you. So a couple of questions about radiology. So is telling a radiologist that your consultant asks you to order a scan usually enough justification if pushed?
No. If you, I mean, that's what I fall back on. But if the radiologist really believes that it's not an appropriate scan, they will just say no. In that case, try and avoid getting stuck in the middle. So there's been situations before where you will end up going back and forth, and you're basically carrying messages from your consultant to the radiologist and back again. Try and be really clear from the beginning if it's a difficult request to your consultant. This has been rejected by radiology, and I think this needs to be a consultant to consultant handover. If you want the scan, they're really not happy to do it, and I've tried my best, and then just leave it to your consultant. And if they still really want it, they'll sort it out.
Absolutely, yeah. I think that's very sensible. Also, just radiologists are doctors, so it's so important to have your SBAR and respect them. Sometimes over the computer you forget who you're speaking to. Not that if you're not speaking to a doctor, you should have respect. Everybody in your MDT, as Ben said, should have respect. But many of them, you know, will mention you're not ordering a scan, you're requesting a scan, you're speaking to a colleague. So it's really important to remember those factors when having these conversations. And yeah, if you are unable to kind of get that information across, speak to your seniors prior to that, I would just say, to make sure that your request is really solid.
Yeah, definitely.
There was another question. I've split Joe's up kind of accordingly, but if you need to vet a scan, will you receive a notification saying that it must be vetted? Sadly not. Or you expect to know what and when you need to vet a scan? I don't know.
Sometimes. So say if it's out of hours, and so say today I had a lady who pulled her NG tube out at like 4 o'clock, which is the worst time to pull an NG tube out. Put a new NG tube in, couldn't get an aspirate. So because I couldn't get an aspirate, she needs to go for a chest x-ray. Because it was approaching out of hours, had it been after 4:30 in my trust, when you try and request that scan, it will flag up and say, this is out of hours, you need to bleep the on-call radiologist. So sometimes it will tell you that you need to do something else, but often you're just expected to know for your trust that if you want an urgent CT scan, don't just leave it sitting there out of hours, you'll need to get it vetted by the radiologist. Yeah.
Fantastic. A few about bloods and cannulas. So when is it your job to do bloods and cannulas? When is it the nurses? How are we expected to do bloods and get the cannulas when others with more experience haven't been able to? And similar on the same, if a nurse asks you to perform a cannula that she or they failed to insert, but you also struggle, who would you go to really? So they're all about kind of cannula problems.
So cannulas. This really depends on the culture of your hospital and what services are in place and at what times. So for example, where I am at the moment, we'll start with bloods because that's easier. In hours, bloods go to the phlebs first. If the phlebs fail, it comes to the doctors. That is because in our trust, there is a culture that the nurses do not do blood tests and cannulas. Some of them will be trained, and if you get to know them well and you treat them with respect, and if they see that you're busy, they will offer to help you out. But in the culture at my hospital at the moment is that cannulas and bloods are doctor's job, and the nurses will do it if they've got time to be helpful. In some trusts, nurses are amazing, and if the phlebs fail, it will go to the nurses, and if a nurse is on that is blood trained, they'll do it, and if not, it will fail and it will come to you. In terms of how it escalates, it is ridiculous when you first start that a phlebotomist who does 50 blood tests a day has missed, and it comes to you, the F1 that has done maybe 10 in the last 2 weeks. But you'll get better quite quickly because all of the hard blood tests will come to you. So all of your practice is on really difficult patients, and you will just get better. If you fail as an F1 on the ward, I generally would say escalate to usually you've got an SHO on who's slightly more experienced, and it's not to say that they'll necessarily be better at taking bloods than you. Blood taking is a skill, but often a bit of luck is needed. So generally at least 2 or 3 of you to try at a ward level, within the F1s and SHO before escalating to usually anesthetics, reg on call, or critical care outreach. If you phone them and you explain, we've had 3 or 4 attempts on the ward, they're really difficult to bleed, we need this blood test for this reason, please can you help? They're usually fairly happy to come. They will ask if anyone is ultrasound trained, and whether someone has had to go with an ultrasound. So that's really useful to get trained in if you can, because if you can say that someone's had to go with an ultrasound, then they have no leg to stand on. They will need to come and help you. Absolutely. And then cannulas are fairly similar. Phlebotomists in most trusts won't do a cannula, but for example, in Leeds on the acute clerking floors, the phlebotomy team would do a cannula, but only at one time in the day, so only in the morning. And cannulas tend to be a doctor's job, but again, nurses are trained in it, and they will help you out.
Yeah, completely agree. I would 100% say as well, just say, don't shy away from them. It feels so overwhelming when you start work because they feel like a new skill, but the more you do, the more you get better and get confident, and it does just take a few weeks or months for you to feel really secure. But they're the little wins in the job, and the practical aspects are just sometimes the really good fun about it. So yeah, don't shy away.
There's no better feeling than getting a cannula that 5 people before have failed. You honestly come out of that room and you feel like you've got a crown on, you're just like, got it. Got it.
But yeah, it's things to. I think Joe's just asked about to get ultrasound trained. I think it depends on your medical school. At Leeds, we're very lucky and we got ultrasound trained. But stick around when the anaesthetics team, if you can, you have time for them to come. When they use an ultrasound, which they inevitably bring, ask somebody to show you, get involved. Your learning is in your hands. So I think you can attend courses at your hospital within your trust. Just maybe ask that when you start your job, or ask at medical school. That same. And then last question, which just takes us over 8 o'clock. If we refer to a different specialty over the phone, do we have to document that this has happened in the notes, or is that not needed?
Yeah, it needs documenting. Usually in the notes, especially if you've got telephone referrals, because there's no documentation that that's happened. Yeah, just document. Discussed with cardiology, they advised stop 1 antiplatelet. Just what the outcome of it. Some trusts are all electronic, and so if you've sent an electronic referral form, that will appear on the patient's documents as referral to liaison mental health, and then that will get updated within the system. So you don't really need to say that you've done it if there's documentation of it from the referral itself.
But yeah, document. There's no such thing as, maybe sometimes too much, but document everything you've done, because it's so helpful for your colleagues who are next on call. There's a trail of where things have gone and what's been done, so it's really, really useful. Okay, I think that brings us to our end. Again, thank you so much, Ben. Anybody who hasn't yet had time to do the feedback, please just log on to that QR code now. Just to say, all of these lectures are recorded and they're put on our website for you to go back, take your time over and watch again. The next session is on Thursday. That's all about surgical prescribing, and I'm doing that one. So if you want to come along and learn about some surgical prescribing, come and join in the fun. But other than that, I think that's the end. So have a good evening, everybody, and see you on Thursday. Bye.